Dear colleagues, I really appreciate your invitation to be a part of your beautiful conference. My name is Stepan Maruniak, and I'm perfusionist from Kyiv Heart Institute, Ukraine. As you know, since the 24th of February, we have been struggling for our freedom and independence. Therefore, in this presentation, I am going to talk about our work under war-related circumstances. So I have no conflict of interest. Due to war, a lot of the Ukrainian medical infrastructure has been destroyed. Over 700 recorded attacks on health facilities and workers in years since the Russian invasion. About 200 medical hospitals have been completely destroyed. As a result of this action, the rehabilitation departments affiliated with our clinic in Irpin, that is the suburbs of Kyiv, which was occupied, have been damaged. As you can see in the video, the Russian troops leave there and left behind only trash and destroyed equipment. I believe that equipment didn't threat to them. In general, the Heart Institute, located in Ukraine capital Kyiv, is a leading specialized scientific and clinical institution in adult and pediatric cardiology, interventional cardiology, invasive electrophysiology, heart and mind vascular surgery, transplantation, and medical rehabilitation. At the Heart Institute, every year, more than 6,000 cardiac surgeries and mini-invasive operations are performed in 5 modern operation rooms and 4 cath labs, about 2,000 of them with cardiopulmonary bypass. Since the war began, and due to a decision of the Ministry of Health of Ukraine, all planned hospitalization and surgeries have been cancelled. Medical facilities have become military targets, and medical resources have been prioritized to hospitalize injured soldiers and civilians. Nevertheless, we continue to provide urgent cardiac surgery even during activity hostilities around Kyiv. Thus, during the first months, the clinic performed in general about 90 urgent surgery. 42 of them were with CVB in patients with acute coronary syndrome, pulmonary embolism, critical aortic stenosis, and others. Additionally, emergency cardiac surgery were provided for pediatrics, including the youngest, a patient just a few days old with congenital heart disease. For this reason, to protect ourselves and our patient, we made our bomb shelter more safety, blocked all possible weak points. Over the first 38 days from the beginning of the Russian invasion, health professionals stayed and lived directly in the hospital and were available 20 hours per day to provide care to both civilian and the military. Related to frequent air raid alarms and technical impossibility of conducting some procedure in a bomb shelter, the clinic implemented the 2-wall rules, whereas one wall is considered likely to collapse from a missile attack, with the second wall taken on the fragments. Every time surgery was ongoing, there was unwritten agreement that despite the possible air raid alarm and the missile strike that could follow, the patients on the operation table would not be abandoned. Each procedure would be finished. Many times, cardiopulmonary bypass was performed with the background sounds of artillery and air systems. As hospital, we have backup of power supply, but during massive missiles attacks on our power plants, we have some problem with it, especially during urgent surgery. In this case, the air alarm started sounding when we were in the operation room on bypass. In 20 minutes, we heard explosion close to our hospital and electricity out. In another case of blackout during confirmed surgery, as you know, after darkness come lights. We need about 10 minutes to connect our generator to continue working. It's also a moment from power outage. Transport the patient from operation room to intensive care unit on the first video and pediatric ECU working with following two wall rules during air alarm and blackout. Perhaps cardiac transplantation is not on priority type of surgery during war, but we are responsible for our patients who are staying on our waiting list. Therefore, we didn't stop performing heart transplants. It's pretty difficult under such unpleasant conditions. In spite of dealing with a lot of problems, we performed 21 heart transplantation last year and 13 this year. Most of heart transplantation were performed not in our hospital. We can't use helicopters for delivery donor organs during material law, and we don't have heart box. So we delivered a recipient to the hospitals where a donor are. Basically, there is not cardiac surgery department in those hospitals. Zhytomyr, Sumy, Poltava, Odessa. It is not full list of towns where we perform heart transplants. Shortly after patients were extubated, they transported to our hospital for further rehabilitation. One of the main problems is transportation of our equipment. After we load into our bus Herland machine, heater-cooler unit, ECMO, cell saver, oxygenator, and some surgical equipment, we go on our way. For instance, the distance between Kyiv and Odessa is about 600 kilometers. Some hospitals even don't have elevator, and with help of other colleagues, we deliver our equipment to operation room. Sometimes it's really difficult, as you can see on the video. Unfortunately, there are a high gap between organ needs and donor organs. So we try to expand pool the donor's head, and sometimes we performed mitral valve repair on isolated heart before implantation, as you can see. Also, in two cases of heart transplant this year, we used ECMO to wean patient from cardiopulmonary bypass. One case was in Sumy, about 400 kilometers from Kyiv. Patient also had major bleeding that we was not able to stop by hemostatics. So we provided reinfusion blood system by using venous reservoir from Harlan machine and two pumps. One sucked blood to the reservoir, another returned it to central venous catheter. To be honest, this system was on the frame from laundry basket. After stabilization of patient condition, we transported him on ECMO with reinfusion to our hospital. Unfortunately, the patient died in 2 days. Another patient had right ventricle failure after heart transplants in our hospital. Therefore, we were not able to wean him from cardiopulmonary bypass and used for it ECMO. Unfortunately, Protect Duo cannula is not available in Ukraine now. Also, I would like to notice that it became to routine our practice to take also some additional sources of power, for instance, charger station. Now we are actively preparing for heart lung transplantation. Our surgeon passed training abroad in European countries, and also for better practice this skill, we perform experimental heart lung transplantation on pigs. To be honest, it was my first experience of providing CPB for animals. We also don't forget about continuous professional development and arrange different medical conferences. For instance, 15th British Ukraine Symposium with extracorporeal life support and cardiopulmonary bypass section and different workshops that was held on hybrid format a few weeks ago. Due to Russian terror, the most events were held in basement. This basement was made to protect in cases of nuclear attacks. Therefore, it's one of the safest places in Ukraine now. During the war, we have one more reason to use CPB. It's combat injuries, especially penetrating heart injuries with fragments removal both in military and civilians. To find the fragments in the heart, we usually made CT, but sometimes the fragments can move and it's difficult to find it. So for this reason, we also use the arms that give us information in real time. So during this period, we performed 8 of pump fragments removal from the heart. In all this case, heart lung machine was available at the operation room and circuit was primed. I guess some of you could saw this video with fragments removal. In 3 cases, to remove fragments from the heart, we use cardiopulmonary bypass under normothermia with artificial electrical induced fibrillation. To ensure hospital autonomy, we drill a well for uninterrupted water supply to the hospital, installed additional electricity generator, and stocked up of fuel. However, the problem arose: oxygen tanks, which centrally provide oxygen to our and neighboring hospital. The risk of possible detonation during shelling made it impossible to use and refuel these. Our change was to supply oxygen to our operating theater. We found a solution that I would like to demonstrate on the example of a clinical case. Patient K was injured on battlefield as a result of sniper attack. He was evacuated from the battlefield by the fellow military medic. During evacuation, they both were blown up by a landmine. The medic died on spot. Our patient survived and was urgently evacuated to us. Given the sign of tamponade, the patient underwent pericardial drainage, had hematoma removed in the right ileocecal angle, pneumothorax drained, and received surgical treatment to injured right hand. Following stabilization of his condition 2 weeks later, the patient underwent right coronary artery bypass grafting under cardiopulmonary bypass with the removal of fragments. After the start of cardiopulmonary bypass, the minimum hemoglobin level was 9.2 gram deciliter. Oxygen delivered during CPB was maintained more than 272 milliliters, with the minimum blood flow 2.4. Change in mean blood pressure during cardiopulmonary bypass did not exceed 20% of baseline. As a source of oxygen during CPB, we use oxygen concentrator. The maximum flow of oxygen in oxygen concentrator was 5 liters per minute, and VO2 reached 90%. VO2 could be controlled by mixing oxygen from the oxygen concentrator and the air flow to the mixer. Thus, we supply oxygen flow of 2 liters per minute and 1 liter per minute to air to the mixture allowed us to provide 68% VO2. As anesthesia machine, gas analyzer we use to monitor the VO2 of the resulting mixture. The effectiveness of use of oxygen concentrator during CPB was also confirmed by a result of the analysis of blood gas and cerebral saturation, not decreased below 10% of baseline. The mean intraoperative lactate level also did not exceed the reference value, which indicated a normal level of tissue perfusion and tissue gas exchange. Electricity-induced ventricular fibrillation was used and lasted 25 minutes. Duration of cardiopulmonary bypass, 48 minutes. Positive verbal contact was recorded 18 minutes later after anesthesia, with positive dynamic on ECG. Currently, the patient undergoing rehabilitation, and this case has showed that in case of urgent need and deficiency or inability to use central realized oxygen, it's possible to safely use an oxygen concentrator as main source of oxygen during cardiopulmonary bypass. Finally, I would like to thank all my colleagues, especially our perfusion team, who since the war started have been working under missile strike. We have never lost optimism and hope that this terrible war will end and we will once again be able to provide cardiopulmonary bypass under normal conditions. Also, I would like to thank Professor Boris Todurov, who is the General Director of Heart Institute, for maintaining our hospital work, and Professor Oleg Loskotov, who is the head of Department of Anesthesiology and Intensive Care, and who maintain our scientific work under such conditions. We wish and thank everyone who supported us during this difficult time. Thank you.